So yesterday I talked about this, and so those of you here yesterday already know the answer, and I suspect you've already texted in your vote for me. So if you need to get up and go get some coffee or stretch your legs, that's all okay. Now I will say I was a little thrown back. I looked at the schedule this morning, and I thought when I'd seen the original schedule, I was debating Mahesh Ramchandani, one of my older partners. And I was going to try to pull a Trump on him and say, well, you know, we're not sure if he has a criminal background, but maybe we should look into it. But he's not here, and it's going to be Ross, and so I'm just going to have to point to his youthful exuberance. Now, the other thing I was going to comment on after the last talk is they talked about Class 1 recommendations and level of evidence C, and I think a lot of people misunderstand what that really is. Now, for those of us in the crowd that are a little older, maybe like my colleague Dr. Quinones, remember when Copernicus said that the Earth was not in the center of the universe, that the Earth actually went around the sun. And that really upset Pope Pius IX because the church taught the Earth was in the center and everything went around the church. And so he convened a conclave of all his top bishops and he said, listen guys, the church says the Earth is in the center and I believe them. What do you think? And they all said, we're with you. And so they issued church guidelines. The Earth is in the center of evidence, Class 1 recommendation, level of evidence C. Now, the reason I bring that up is that TAVR is great because we've actually done the real evidence in TAVR, and there's more Class A and B evidence in TAVR than I think anything else in the world. So I'm going to be pro on this, so I have some disclosures. I am a surgeon. I also have grandkids that I want to support and other things. So, you know, I feel strongly about this. But, you know, we saw this yesterday. We know in high risk that we can actually beat the mortality of surgery. We know we can get better hemodynamics, and we know that there's not any more, at least early, structural valve deterioration based on very stringent guidelines of a 50% increase, which favors surgery since they start higher anyway. We also know that we looked at this yesterday, the common theme on all the trials is that surgery has more bleeding and transfusions, more acute kidney injury, and more atrial fibrillation. And that's unlikely to change as we go down. Just like our hemodynamics are unlikely to change as we go down. And the major vascular complications are getting better, and then the pacemakers have never been a problem with the early balloon expandables, and they're getting better with the other valves. We looked at this. We know that at least in high risk, TAVR wins on mortality, it wins on hemodynamics, it ties on quality of life, it wins on acceptance, and there were a couple of things we're going to work on: morbidity and durability. Of course, by the time we figure out durability, we're going to be another 12 years down the road. I'm going to be retired. Matt's going to call me out at my ranch and say, hey, Mike, we finally got the answer. We saw this yesterday, the Partner 2A trial. Matt helped run the Partner 2A trial. It was a great trial. Again, now we're getting down to some real evidence, randomized prospective clinical trials. And this was the second generation valve, not the current generation valve. And numerically, we did better for TAVR versus surgery. Now, your statisticians will tell you the blue line and the yellow line are exactly the same. I'd rather have my mama on the blue line. And we looked at the non-inferior impact, made that very easily. And then we go to the all-cause mortality or disabling stroke for the transfemoral. It's actually superior. And how many were transfemoral in the trial? About 90%? Well, that's where we're going. This is what we're going to deal with. And as we move into lesser risk patients, I think there's going to be more and more transfemorals. And Certavi is going to come out, so we'll have some good data on that. We also saw the S3 intermediate. S3 is the newest version of this valve. They added some structural changes to the basket, and they've added the skirt to cut down on the PVL. And it was indeed non-inferior when we looked at the primary endpoints, and it was superior when we looked at comparing it against a Partner 2A intermediate risk surgical cohort. Now, this is non-contemporaneous, but it was a pre-planned, specified propensity matching. So it's pretty good. It's about as good as we can get without actually doing a randomized trial. And the good news is we're going to get a randomized trial with S3 because it's going to be the low-risk trial, and we're going to get some real answers from that. So if we looked at the superiority analysis, when we compared against that, it was superior for mortality, it was superior for stroke, and it lost on PVL. But you know what? It didn't lose by much. And that's creeping towards the center line. If we look at adjusted time to event all-cause mortality in this comparison, again, your statisticians will tell you, well, you can't make anything from these lines. This was 2 different trials and it's post hoc analysis. But again, I'd rather be on that blue line than on the yellow line. And very surprisingly, look at this moderate PVL at 1.5%. Now we see in these trials, what we're seeing from the centers of excellence, the moderate rate is it's less than 1%. It's a small percentage. But if you look at a meta-analysis of what happens in the community, out in the real world, by 1 year, it's almost 4%. It does happen out there. It just doesn't happen as much if you're at a center of excellence. We looked at the Notion trial yesterday. Again, it was a pre-specified superiority trial, started in 2009, before we really even knew how to do these, up in the Nordic countries, with a composite endpoint of death, stroke, myocardial infarction, and it didn't reach its endpoint of superiority. Not a surprise. They only really recruited about 140 people in each arm over a period of many years. But if you'd had more people, this would have reached superiority. Again, I'd rather be on the blue line of TAVR. If you break it out to individual things, death, I'd rather be on the blue line. Not enough numbers, not surprisingly. If you get more numbers or we can follow that long enough, we may well reach superiority, but it's going to take a long time. Stroke, I'd rather be on the blue line. Myocardial infarction, I'd rather be on the blue line. This was an all-comers trial. This was already an intermediate low-risk trial. It's clearly non-inferior. I'm not a statistician, but if you're less, you're non-inferior. It doesn't take a lot to figure that one out, no matter what margin you choose. And since we're talking about a less invasive procedure, again, ties can go the runner. I talked about this yesterday. Surgery has some problems. I love doing surgery. It's what I do. I've done it all my adult life. But surgery hurts the heart. I put you on bypass. I give you cardioplegia. I freeze your heart. What happens? It doesn't work as well. Your stroke volume goes down. And it takes it about 6 months to get better. Now that's, the younger and healthy you are, the more you can survive that. But do you really want to hurt the heart if you can find a way to not hurt the heart? And again, it hurts the right heart. And all of the surgeons out here will tell you, nothing worse than a bad right heart. I'll deal with a bad left heart any day, but a bad right heart makes it hard to get better. And we looked at this yesterday. This is a very interesting graph. We're going to talk about this more in depth at the AATS this year. But this is the instantaneous hazard rate risk of death. Now already the yellow bar for TAVR on the day of the procedure has dropped way, way down. Because when I looked at every single one of these, almost all of these were things like wire perforations of the heart. We were just learning this procedure. It still happens, but it happens very rarely now. And so the 30-day interval would probably now come out in favor of TAVR, and that's exactly what we saw in S3, when it really dropped so low, where we're now looking at a mortality of like 1%. It's very hard to compete with. And the recovery phase is still a problem for surgery, and it's still going to be a problem even as we go to lower and lower risk. Now, I think that this bump is going to become less, but let's just assume for a minute that it goes away entirely. And these lines lay on top of each other. What are your patients going to choose? They're going to choose TAVR. There's no question about it. We have 2 low-risk trials that are coming out right now. They have the Medtronic trial, and we have the Partner 3 trial. Again, we're not going to count on level of evidence C. We're actually going to generate some of the best data in the world to make up our minds on what to do this. And so far, the data will tell me, based on what I've seen, that there should be an IFE for intermediate risk. No question in my mind about that. The only question that remains is low risk. And we're going to run these 2 trials with some minor differences in them, and we're going to get the answer for low risk. And again, remember that when we ran these original IDE trials, to be a surgeon in the trial, in both of them, and Matt, correct me if I'm wrong about partner, at least in the Medtronic trial, you had to have at least 5 years of surgical experience as an aortic valve surgeon with a certain amount of high-risk aortic valve, or we wouldn't let you in. How much TAVR experience did you need to get in the trial? Yeah, we just pulled you off the street and said, hey, you want to try TAVR? Nobody had done this. And so these trials were intrinsically biased towards surgery. And yet, TAVR won those trials. Now, it's going to be interesting to see now that we're going to do the low-risk trials, because now we're using centers of surgical excellence and centers of TAVR excellence. So it's going to be interesting to see where it goes. So TAVR has already had a lot of improvements, and a lot of the technical disasters have already been corrected. But that has, surgery is about as refined as it's going to get. Moving to a sutureless valve is really not much different than doing a valve. That's not going to change it. And again, we talked about this yesterday. Surgery is technique-driven. Anything that revolves around technique takes a long time to learn. Heart surgery is a complex thing. Just like being an interventional cardiologist is a complex thing. It's hard to learn the techniques to do an aortic valve. It's hard to learn the techniques to do a CTO. But when it gets to time to deploying the device, that's a lot easier to do because that's technology-driven. And therefore, it's going to be adopted across the country, and people that don't have really good heart surgeons are going to have really good TAVR docs, And so they're going to move it in favor of TAVR, whether you want it to happen or not. And again, I think we're really changing the way we think about this. I don't think every single case is going to go to TAVR right now because some of them just aren't good cases. But we're no longer going to ask who's a bad case for surgery. Maybe we should consider TAVR. We're going to say, listen, does this patient really not fit TAVR? Is there something about this anatomy that's bad for TAVR? Well, yeah, if so, then we'll consider surgery as a second-line choice, not as a first-line choice. So again, risk, right now risk is we used to draw these little boxes, a low-risk box, an intermediate risk box, a high-risk box, an extreme risk box, as if there was some sort of dividing line between what is low, intermediate, high, and extreme. And in fact, these are all funny numbers anyway, because the high risk that we were doing was the top 10% of what we were doing. The intermediate risk is still the upper 25th quartile of what we do as surgeons. I mean, if my understanding of intermediate is the middle, intermediate would be an STS of about 1.8. And we also know that as implanters, we have drawn these two lines. There's a line above which we don't go, but we're not talking about that today. And there's a line of which we have not gone below because we're restricted by what the FDA tells us. They don't do that for surgical valves. They don't say you can use this valve, Mike, in an old sick person, but don't use it in somebody healthy. They just say, here's a valve. You make a decision. You're the doc, you decide. And we know these lines are going to move to the left. And the only real question is how far are they going to go, and it's all going to be related to durability because we're going to solve PVL and we're going to solve pacemaker. And even if we do have pacemakers, we're going to get us leadless pacemakers that aren't going to cause TR. These things are all going to happen in the next 10 years. But we don't know durability, and we're not going to know durability from the ID trials because these people are 83 and a half years old. And what we know about structural valve deterioration is that the older you are, the slower it occurs. And so in people that are 83, if we put surgical valves in them, Matt and I wouldn't expect any of these to wear out in their lifetime because they're 83. They're going to die before they wear out. But we are going to do the lower risk, and we're going to find that out. But we also know from surgical trials that you need at least about 7 years before we start seeing any signals. So once we get the intermediate and low risk trials, we're going to have 10 or 11 years of follow-up to get enough people to 7 years before we'll know. And I've done the math. I'm going to be retired by then. So we know if durability is found, there's absolutely no question that unless you're anatomically not a candidate, everybody will get a TAVR instead of a SAVR. Thank you very much.
Well, I feel kind of like Rocky Balboa being brought up to fight Apollo Creed to give the folks a good show. Of course, watching the presidential debates, I learned one thing, that there's a lot of gimmickry and toying around and things. So I was really looking forward to debating Dr. Reardon. But I can't go out and call him Lying Mike because I agree with everything he says, and I can't abuse his character or his surgical technique. So all I can do is the great old debate technique of trying to build up your opponent so big that any little win that I get is a big win. So I went home after seeing all the talks yesterday, and Matt and Neil and Mike and saw their talks, and I went home and took out every slide that I had that talked about the clinical trials because I didn't want to be redundant. I agree with everything that has been said about the high risk and the inoperable patients and the intermediate risk trials that are going on now, but I'm going to talk about some of the other issues. So the question was, will TAVR replace surgical aortic valve replacement in low-risk patients? And the question is, will it replace? And I want you all, ladies and gentlemen of the jury, to remember that word, will it replace surgical AVR? So we've gotten pretty good at surgical AVR. The risks have gone down. Looking at operative mortality from the STS database, this is in a group of patients who are greater than 65 years old. And the operative mortality for isolated AVR was 3.9%. And the overall median survival after AVR in patients between 65 and 69, 70 or 79 or greater than 80, overall they had pretty good median survival, given the fact that with severe aortic stenosis, the median survival of most patients is less than 2 years. So we've done pretty good in the surgical arena at bringing the risks down, and a lot of innovations, a lot of things have been done. We do some more minimally invasive operations in elderly patients, and we've made a lot of advances in pre and post-operative care that have really brought the risks down. So how did we get to the point of safety for a big operation like aortic valve replacement? When the first aortic valves were put in, this was about as big an operation as you could do. You had not enough blood to prime the pumps. You had early pump oxygenators and pumps that were very dangerous. And we had valve devices that had never been tested in humans. So we had a lot of obstacles to overcome, and we learned lessons from mistakes made. We learned lessons from collecting and analyzing the data, and we didn't do it as well as Dr. Reardon and Matt are doing right now, and Dr. Kleiman. We neglected to analyze the data as well as we should have, and I think we've learned from that now. And as we put out the new technology, it has to be guided by experience and by observation. And that's what we're doing with the intermediate risk right now and going into the low-risk trials. But if we do not know the history, we're destined to repeat it. And so these were some of the mistakes made and some of the lessons learned. This disc was biodegradable, and it would chip away and fall apart inside the body, and then it would flip out of its little cage and go up to the carotid artery or somewhere where it shouldn't be, and that caused problems. Some people were worried that the silastic ball was getting traumatized by the metal struts in this iteration of the Starr-Edwards valve, so somebody had the great idea of putting Dacron around the metal struts. That didn't work out so well. We knew that certain generations of, the early generations of tissue valves broke down early in the younger patients, but we didn't know that until we had thousands of these implanted. And so we learned those lessons. We also learned lessons about how to store the valves, how to process them, and anti-calcification treatment, as well as the structural integrity and how to mount the tissues, what types of tissues to use. All of these lessons that we've learned are now going into TAVR to make it much more safe to proceed forward. So one of the lessons was that younger patients had their valves fail earlier than older patients did. And it wasn't just because the older patients were dying, it was that the younger patients' valves failed quicker than the older patients. So with this knowledge and what we found over the years of putting tissue valves in, is TAVR with a tissue valve justified in younger patients? If we're going to go to low risk, we're going to be talking about patients that are younger than 70. When I was in surgery residency, the attending surgeons used to tell me anybody younger than 70 gets a mechanical valve, anybody over 70 gets a tissue valve. There were no questions asked. I think we've changed that way of thinking. And the evolution towards accepting tissue valves in younger patients has been ongoing, really because of the better durability in the third generation tissue valves. The long-term risks of Coumadin are being identified, and the possibility of valve-in-valve has been a more recent trend. But the long-term survival appears to be equivalent in younger patients when they get a tissue valve or a mechanical valve. And these are some of the problems with mechanical valves. It's not just a matter of switching, taking Coumadin every day or having your valve explanted in 15 years. There's really a lot of possible complications and risks of having a mechanical valve. This is a study that went out to 15 years. They looked at valve-related deaths, and patients who had deaths for other reasons, house fires, car wrecks, bleeding, thromboembolism, major risks. So the patients at 15 years who are living free of major complications was only 23%. So these younger patients that we were putting mechanical valves in didn't really reap the rewards of having the mechanical valve. So over the years, we've seen a trend. The STS database showed from 1995, where about 60% of patients got mechanical, to 2001, where 36% got mechanical and 60% got tissue valves. And you can't explain all of this with an aging population over a course of 6 years. So it's been a trend of accepting tissue valves in younger patients. Cleveland Clinic showed their choices of bioprosthetic valves going up over the years, and a national trend of lowering number of mechanical valves, increasing number of tissue valves. And this study by Dr. George Rule, looking at 30-year interval after aortic valve replacement, the AVR and mechanical or tissue valves were similar. More recent trial looking at patients aged 50, 59 in the New York State Registry, showed that after 15 years, the lines were superimposed. So tissue valves are acceptable in younger patients, even in their 50s. And so I think we can extend that to TAVR as well, even though we don't have any long-term durability data, and I'll talk about that. So the TAVR risks overall are improving, and I agree wholeheartedly with the fact that TAVR is now showing that it is probably superior to surgical AVR in some subsets of patients. What we've found is that the valve design is allowing for delivery through smaller sheaths, and this was revolutionary because I was part of a group that was putting in a whole lot of transapical valves. That was a tough run, and very large sheaths were wrought with complications. So the percutaneous access and closure has really changed things a lot, avoiding alternative access wherever we can. As Dr. Reardon said, we rarely have to use alternative access. Most are transfemoral. Decreasing need for general anesthesia, decreasing femoral and iliac artery complications. The iliac on a stick was devastating. But newer balloon and marker designs allow for more stable deployment and easier valves to align. Flexible delivery catheters are really helping us maneuver the aortic arch, and we get a more favorable aortic valve crossing angle, so some of these valves are designed to give you a more favorable angles of deployment. The retrievable device is the next revolutionary movement here, that if we don't like the place where this valve is being deployed, we can move it and do it again. And that really is going to be a game changer for PVL, avoiding embolization of the valve and possibly decreasing pacemaker dependency. The skirt design on S3 was nice and has shown quite a bit of decrease in PVL as well. So the technological advances are really pushing us towards a goal of universalizing TAVR more. It's making the operator dependence much less variable. Experience has also changed the game here, and worldwide operator experience, people in this very room who are going around and proctoring other surgeons, the way that they structured the training has been very good for promoting experience and decreasing the learning curve. Proctors, mentors, collaboration across the country, across the world, across disciplinary lines, and individuals overcoming the learning curve now that with much more worldwide experience is increasing our ability to have better outcomes. The data collection and analysis, as Dr. Reardon has stated, is amazing. Multi-center clinical trials, randomized trials, registries, and subgroup analyses are improving our knowledge of how we can make these valves better more quickly. And then the multidisciplinary allies, not just across cardiac surgeons and cardiologists working together, anesthesiologists, radiologists, everybody working together, but also with R&D and the scientists. Everybody's working together to combine the talents and perspectives to overcome these novel obstacles. Patient selection, the lessons we've learned about which patients to do in the commercial TAVR series has been phenomenal. So with all of this, is TAVR safe to offer to low-risk patients? And what data do we have to support that? So we know that the clinical trials and registries support TAVR with superiority over conservative treatment in inoperable patients, non-inferiority in some trials, superiority over surgical AVR in high-risk patients. The intermediate risk trials are ongoing, and we're all looking forward to those results as soon as we can see them. And the low-risk trials are opening now. So these things are going on, but the data we have are in high-risk and inoperable patients. The lower-risk patients and the intermediate risk patients that were included in the registries and clinical trials had favorable outcomes, and people are pointing to that right now, saying that compared to historical surgical groups, that lower-risk patients in the trials and registries are showing some benefit. But you have to remember that lower risk by the STS or Euroscore, deemed by 2 cardiac surgeons to be high risk for SAVR, may have other risks and complications as well that aren't truly low risk. So the big questions about TAVR safety, and these are the things that we have to overcome before deciding that we're going to open this up to low-risk surgical patients that otherwise would have a very low risk of operative mortality and good long-term survival. So paravalvular leak, I think, is a very critical question. These days, as Dr. Reardon showed you in the data, it's rarely more than mild. But we're still trying to figure out, does mild paravalvular leak affect the patient's quality of life and survival long term? And if we're going to go to a low-risk patient population, these questions have to be addressed. But more and more, the safety of these valves, the repositioning of the valves, redeployments, we're seeing lower and lower paravalvular leaks. Permanent pacemaker results in some of the trials have been between 5 and 12 for balloon expandable stents and 24 to 33% in the self-expanding stents. Some of these numbers are getting better, and we're learning a lot on where to place the valves and how to try to avoid pacemaker requirement. And that's another question in a low-risk patient population is if you're going to be pacer dependent, what role does that have on your quality of life? If it's true that the pacemaker requirements go down after several months, then these patients can walk around with a pacemaker device turned off, and that might be, or turned down, and that might be okay for their quality of life. Vascular injuries are now rare, much more rare with the 14 to 18 French sheaths. Stroke has been a problem depending on how hard you look for it in both surgical AVR and in TAVR, and the stroke rates are declining almost in half in the more recent trials. The newer generation valves, the more experience, the lower profile sheaths, everything is making stroke rate less. These other problems, while they're very rare now, they were higher in our early experience, but they do happen. As more operators begin to use the technology, you're going to see learning curve problems, and you're going to see some of these problems that could be avoided or maybe couldn't be avoided. But the things like valve embolization, aortic dissection, annulus rupture, LV perforation, coronary obstruction, they're very rare. But if they occur in a low-risk patient that has a 1 or 2% mortality risk from surgical AVR, that's still a big problem. And durability is unknown yet. So you can see some of these complications can still occur. You can see this dissection flap after a TAVR. This patient had an LV perforation, probably due to the wire, and you can see the contrast coming out of the LV here, requiring opening the chest and putting a couple stitches. And this, another devastating complication. This was a transapical approach, but you can see this is kind of a nightmare when the valve embolizes. Again, these complications are much less now, but when they happen, they can be quite devastating. And this is a slide I don't want to stick on. Seen this enough. So, and then paravalvular leak. Looks like this video is freezing up, but paravalvular leak still happens. We usually don't leave the operating room until it's mild or less because we can now. So these are the data we have on long-term TAVR durability in the young, low-risk patients. But I'll let you know in about 15 years. So in lessons learned and looking back at the past to try to avoid repeating history, this was an article by Enescu saying that the long-term durability of the glutaraldehyd stabilized pericardial xenografts was demonstrated by rigorous, complete clinical follow-up as well as histologic and hemodynamic investigations, and the superior hemodynamic performance of this valve, even in very small sizes, represents an additional advantage and makes it particularly suitable for use in patients with a narrow root and in children. And they said the very good results obtained with the pericardial xenograft fully justify its continued clinical use in the aortic, mitral, and tricuspid positions. This was the Enescu-Shiley, and this was another article out of Japan talking about the great hemodynamic results in the lab, how the hydrodynamic forces in the research lab made the Enescu-Shiley valve much better than Bjork-Shiley or Hancock. And this was an article looking at 2,680 implants next door, and the written by Dr. George Rule, and this was looking at the early results on excellent hemodynamic function and low thromboembolic rates of the Nescu-Shiley bovine pericardial bioprosthetic valve. Encouraged us to use it as our valve of choice for implantation in 2,680 patients. And analysis at 5 years demonstrated the following trends. Said the actuarial freedom from reoperation resulting from valve failure at 5 years was 82%. And they said, thus we have limited the use of bioprosthetic valves to a select group of patients in whom valve longevity is less important than effective orifice size, thromboembolic rate, and freedom from anticoagulation. So with the 5-year data, they had great results, and they were implanting these in everybody they could find, even children, and they learned later on that durability was a problem because of valve design. So we have to try to keep that in mind and avoid that problem. So bicuspid aortic valve, we don't know yet. There's a lot of complexities to that. So in conclusion, TAVR definitely has favorable results over surgical AVR in high-risk patients. The intermediate and lower-risk patients undergoing TAVR have had good results also. Intermediate-risk clinical trials are nearing completion, and the evolution of TAVR technology and operator experience is resulting in dramatic improvements in the outcomes. But currently, no data exists to determine whether TAVR is as safe as surgical AVR in young patients. Unanswered questions include the outcomes with mild PVL, the quality of life in patients with pacemakers, and the TAVR tissue valve durability long-term in young patients. So this sets up a perfect situation for randomized controlled trial, and we're really looking forward to that. So do we concede to the end of surgical AVR and send all the low-risk AS patients to TAVR right now? Will TAVR replace surgical AVR? I don't think so. So thank you very much.
So Ross built everything about durability. He's absolutely right. Durability is going to be the key to this. I took out a lot of the Nescu-Shiley
Turn
valves
off the microphones, please.
with Ross's dad. That's how I learned to redo valve surgery. But remember, we've never, as surgeons, let data stand in the way of us doing something or lack of data. And every new surgical valve that comes out without any durability, we all jump on and put in any risk patient that we want. And so the question is, will it replace it? It's all going to have to do with durability. And if we follow the surgical world, the data really won't matter. We'll just do what we want to do.